Good morning, everyone. Thank you for joining PHCA for today's webinar entitled Navigating the New CMS Quality Measures. My name is Abby Foster. I'm the Director of Marketing and Member Services at PHCA. PHCA offers monthly webinars for members for NAB-approved credits. We have over 150 individuals on today's webinar taking advantage of this member service, and we thank you for joining us. Before we get started, I have a few housekeeping items to cover. The slide deck that was emailed to you in the registration reminder this email this morning should be on your screen. If you have dialed in by phone, please select telephone and enter your audio PIN. This webinar will be recorded and made available on the PHCA site following. The webinar has been approved by NAB for 1 credit for nursing home administrators and 1 nursing continuing education credit. Certificates will be emailed to attendees following the presentation. If you need the nursing credit, please reply to the email with the nursing home administrator credit and let me know and I will send it. Please submit questions using the questions pane. We will use the time at the end of the formal presentation to have our presenter answer these questions. All attendees will be in listen-only mode. On March 3, 2016, CMS introduced 6 new quality measures to be posted to the Nursing Home Compare site in April. 5 of the measures will be integrated into the new CMS 5 Star Quality Rating system later this year. The objective of today's webinar is to discuss the CMS new quality measures and differentiate the measures that will be integrated into the CMS 5 Star Quality Rating system later this year, explore best practices that can be integrated into operations to improve these new measures, and describe the strategies that can be utilized to communicating to referral sources on the changes of the CMS 5 Star Rating system. The webinar will be presented by Dawn Murr-Davidson, PHCA's Director of Quality Initiatives. Dawn, the floor is yours.
Thanks, Abby. With me today I have Rachel Delavan, who's our Director of Research as well. So there's a lot of information that will be coming at you the next hour or so, and we'll do our best to save some time at the end for questions. If we can't answer your questions because some of this is very real time, we'll do a FAQs that we can put out on the website as well. So our objectives today are to discuss the CMS Nursing Home Compare new quality measures and to differentiate the measures that will be integrated into CMS 5 Star Quality Rating system later this year. We're going to explore some best practices that can be integrated into operations to improve these measures, and we're going to describe strategies that can be utilized when communicating to referral sources on the changes of the CMS 5 Star Rating system. So Abby briefly gave you an overview of the timeline of events, but we'll just go into that a little bit deeper. As she said, on March 3rd of this year, CMS announced the new quality measures. During the 3rd week in April, CMS made preview reports available to providers in the KEYS system. So I think many of you are probably in the habit of already going in and looking at these preview reports, but definitely something that as CMS continues to introduce new measures, you want to integrate this into your quality and your operational practice. And if you are not familiar with accessing the KEYS system, probably your RNAC or the person who submits your MDS can help with that, or we do have a resource guide on our website as well. Then on April 27th, which is just about a week ago, CMS published the 6 new quality measures on Nursing Home Compare. These new quality measures increased the number of measures to 15 long stay and 9 short stay measures overall. I think one of the things you'll notice as we go through today's webinar content is that some of these measures begin to cover domains that were not currently covered by other measures. And that's very much intentional on CMS's part. And the new measures also introduce a new method of looking at the measures, which is the claim-based measures. And we're going to talk a little bit about what that means. So just an overview of the claims-based measures. The thought behind using claims-based data is that this data may be more accurate than MDS-based measures. And you'll hear me mention several times today about the importance of MDS coding, and there's been a lot of I'll say concern by CMS of nursing homes self-reporting data. So by some of these new measures utilizing claims data, they're trying to create a more accurate picture of what's happening in the nursing homes. The claims-based measures only include Medicare fee-for-service beneficiaries currently, but some of the materials around the claims-based measures indicate that this will evolve, just like everything else. And then the claims-based measures are risk-adjusted using items from Medicare claims data, as I've mentioned, and the enrollment database, and they will integrate, and you'll see this as we go through today's materials, MDS elements. So here's a table of the new quality measures, and they're broken down by short stay and long stay. And I've also indicated the source of the data and when, based on our understanding today, CMS intends to include these in the CMS 5-star rating. So the first measure is percentage of short stay residents who were rehospitalized after a nursing home admission. You can see this data is going to be pulled from claims data, and it's expected that this will start being included in 5-star in July of this year. The second measure is the percentage of short stay residents who have had an outpatient emergency department visit. Again, a claims-based measure, and it's expected for 5-star in July. Percentage of short stay residents who were successfully discharged to community. Again, this is a claims-based measure and will hit 5-star in July. Some of our members started looking at this probably about a year ago. I know PHCA, as part of our quality initiative plan, has started looking at discharge to community as well. Then the last short stay measure that is new is the percentage of short stay residents who made improvements in function. This is an MDS measure, and again, we're looking at a July CMS 5-star rating implementation. The two long stay measures that are new are both MDS based, and the first one is percentage of long stay residents whose ability to move independently worsened, and we're expecting to see that one in July. And then the last one is the percentage of long stay residents who received an anti-anxiety or hypnotic medication. And this one, depending on the source, we've seen as early as July, but based on the CMS call last week, we're thinking this one will be phased in last in probably January 2017. So again, this is the timing based on our information that we have currently, and as we continue to get more information from CMS, we'll continue to update our members. So as you can see, this is a screenshot from Nursing Home Compare with a little narrative on the look back windows, but you can see that the new measures are out there and they're flagged as such. This is a screenshot of the short stay measures. It has the individual nursing home, the Pennsylvania average, as well as the national average. The three claims-based short stay measures, the look back is there for you. It's July 1, 2014 through June 30, 2015, and then the MDS measures will have the 3-quarter average method, and that time period is there as well, April 1st, 2015 through December 31st, 2015. Before we get into each individual measure, I just wanted to spend a few minutes reviewing the elements of a quality measure. Many times when I'm working with members, they'll need some grounding, if you will, on kind of what does each of the elements mean. And so I just wanted to make sure we all were on the same page for today's webinar, because a large chunk of this educational content is really going through each of these elements and what does that look like for each measure. So the obvious one, and probably the easiest, is that each measure has a name, and I just introduced the names of the new measures. Each measure also has a purpose, and that is a description of what that measure is and what it may indicate. And we'll go through each one of those for the 6 new quality measures today. Each measure has a description and specifications, a numerator, and this is, I think, where sometimes people need guidance. And so as we go through today's slides, we've listed it in a couple of different ways, and hopefully you'll be able to take this slide deck or parts of it and pull it out and utilize it as part of your quality processes as you go through. So the numerator is a subset of the denominator population for whom a process or an outcome of care occurs. It represents a clinical action to be counted as meeting a measure's requirement. So for example, a patient who receives a particular service or obtained a particular outcome that is being measured. One example may be patients who had a diabetic foot exam. The denominator is a subset of the initial population, so it could be patients with diabetes. And for some measures, the initial population and the denominator are the same. So it may be all patients 65 years of age and older with diabetes. So try to put some examples in there because I think that's where folks can get hung up a little bit. Also, we often have questions around what does risk adjustment mean? And risk adjustment means that the rate basically accounts for differences across nursing homes in patient demographics and clinical characteristics that may be related to the outcome, but not to the quality of care provided in the nursing home. One of the other elements is just how the measure is calculated, and you can see the different definition here of observed rate, that's the actual rate, the expected rate is with the risk adjustment, and then the risk standardized rate, which is the observed rate is divided by the expected rate, which is then multiplied by the nationally observed rate. So it doesn't look like we've had any questions come in yet, so I'm going to go ahead and move into the new quality measures and take a deeper look at those. We'll start off with the short stay quality measures. So the first one we're going to take a look at is short stay rehospitalization, and the description. And before we kind of get into the name and the description, I just wanted to kind of highlight that decreasing rehospitalization is a high priority for CMS. So I don't think we were really surprised to see this measure. And we had some idea that CMS was probably going to base this measure on claims data, which you know, many of us, we don't have that information, so we've been working to decrease rehospitalizations using other methodology or just really putting interventions in place. And so I think the important thing with some of these are not necessarily that you get so hung up in the methodology, but that you're truly looking at the interventions surrounding how do you prevent rehospitalizations and the root cause analysis. With that being said, this measure's name is the percentage of short-stay residents who were rehospitalized after a nursing home admission. Again, this is a claims-based measure. It is on Nursing Home Compare, and we expect that it will be included in the CMS 5-star rating in July. The purpose of this measure is that a resident that is sent back to the hospital may be an indication that the nursing home is not properly assessing or taking care of residents. Now, this is not my definition, nor is this my purpose, but this is, you know, right from the guidance. And so it's important that, you know, again, we're looking at what is the root cause when someone's going back to the hospital, and we're putting interventions in place. So this measure determines the percentage of all new admissions or readmissions to a nursing home from a hospital where the resident was readmitted to a hospital from an inpatient or observation stay within 30 days of entry or re-entry. I think, you know, there's good statistics out there to say that oftentimes when a resident or a patient is discharged from rehospitalization, many times they're coming back within the first 14 or 30 days. So it's important to kind of look at what are those early assessments and interventions that are taking place in those windows to keep the residents, you know, in the nursing home during those 30 days period. To note, if you're looking at rates, your individual rates, or you're comparing, a higher value of the short stay rehospitalization measure actually indicates a worse performance. So in this case, lower is better. This table shows us the numerator and the denominator window. And so for this piece, it includes stays that started over a 12-month period, and the data is updated every 6 months, and you can see the months there with a lag time of 9 months. So I think one of the things that's important, you know, to say as we start looking at these measures and looking at the measures that we expect to see in the future is that really it's important to kind of get ahead of the curve in looking at these measures, because these lag times, obviously are a look back. And so, I think many of you have been working on decreasing rehospitalizations over time, and that work should hopefully pay off as you're looking at your individual rates. And so, we're working hard to kind of navigate and proactively look with HCA at what measures are coming in the future so that we can help all of you to kind of get ahead of the curve. I like to say get in the driver's seat. For the numerator for this measure, it's important to note that inpatient hospitalizations and observation stays are identified using Medicare claims, as we've said a couple of times, and the numerator includes stays that the beneficiaries meet the inclusion criteria and were admitted to the hospital for an inpatient stay or outpatient observation stay within 30 days of entry or re-entry to the nursing home. And that's regardless of whether they were discharged from the nursing home prior to the hospital readmission. The hospital readmission did not meet the definition of a planned hospital readmission. So, meaning that if it's planned, then that's going to be excluded. The denominator includes the measure for residents who entered or re-entered the nursing home within 1 day of discharge from an inpatient hospitalization. And these hospitalizations are, again, you'll hear this common theme, identified using the Medicare Part A claims and entered or re-entered the nursing home within the 12-month period that was targeted. You can see the list of exclusions here. The resident did not have a fee-for-service Part A and B Medicare enrollment for the entire risk period. The resident was enrolled in hospice care during the stay. The resident was comatose or missing data on comatose on the first MDS assessment after the start of the stay, or data was missing from any of the claims or MDS items used to construct the numerator or denominator. And the last one is that the resident did not have an initial MDS to use in constructing covariates for a risk assessment. We're going to talk a little bit about risk adjustment, and we've kind of talked about the definition of that. And in this measure, there's a couple of factors that will go into that, including a comorbidity index, which I'm not going to get so much into today. But the covariates include conditions and diagnoses that were present at the start of the nursing home stay, and that'll be pulled both from claims and MDS assessment data. But it also includes a list of MDS categories, if you will. And I think it's important as we go through each of these measures, this is just an example of the list that's available, and we can send more information out on the total list. But I tried to pull through which ones were areas where, as you're doing your, I'll call them rapid quality cycles, one of the things that you may want to do is, if you're not scoring well with rehospitalization, start looking at some of these MDS factors. And is your MDS being coded accurately? Are there interventions that you can use for care planning purposes? And so that's why we pulled this through for you to kind of look at. This is just the measurement calculation, and we've kind of already looked at this. And then Rachel was kind enough to pull data for us on, based on the current data available from April 28th, where Pennsylvania currently stands, and we're below the national average right now. So, we're not kind of leading the way on this measure, but I don't think we're lagging behind either. And obviously everyone is paying very close attention to rehospitalization. So some interventions or strategies to consider for short-stay rehospitalization. One of the things I think that CMS is starting to turn focus to is prevention of adverse events, and so building prevention into everyday practice. A few months ago, we did a webinar on decreasing rehospitalization by preventing adverse events, and we looked at the breakdown and the category of adverse events around medication errors and falls. And so, continuing to build good prevention into you know, your residents and your staff's practice. Risk assessments. There's a lot of really good risk assessments out there, but a risk assessment becomes more than just checking a box, whether it's an electronic box or a paper box. It's important that when you do those risk assessments that you ensure that interventions are carried out. We're not so much focusing on surveys today, but one of the things that we'll sometimes hear is, well, we did our risk assessment and we were cited. Well, you know, one of the questions become is, great, you did the risk assessment, but were the interventions carried out? Was it care planned? Those sorts of things. So again, the risk assessment in and of itself is not going to prevent the rehospitalization. You truly have to ensure that those interventions are being carried out. Early intervention. Being a nurse and having worked with heart patients for a very long time, you know, with a heart failure patient, what's happening that 48 to 72 hours prior to their hospitalization? Sometimes this is a retroactive look that can happen. You know, did the assessment occur? Were there interventions in place? That early intervention can prevent them from going back to the hospital. Assessment of the resident. This is an area where sometimes I'll have members talk to me about kind of how do we increase or fine-tune the assessment skills of our staff, and that doesn't necessarily just mean an RN's assessment. Our nursing assistants, our dietary folks, our housekeepers, they're all eyes and ears for us, and so, you know, if they observe something, making sure that they're comfortable to report what they're seeing. And then, of course, there is that skilled assessment that becomes so critical in preventing rehospitalization. Communication with physicians. This is a very important one. And as some of the root cause analysis on how measures have improved, some better than others, a big part of that is the role our physicians play. And so it's important that our nursing staff and our medical directors are communicating and really looking at best practices, and when you have physicians that you're calling outside of your building, you know, ensuring that the nurses are giving the right information and that total assessment. We had a question come in that the slides need to be enlarged, so Rachel's going to work on that while I continue. Oh, sorry, Rachel's looking at the questions while I continue. So communication with physicians, and then collaboration with hospitals and referrals, referral sources. One of the members I was with some time ago spoke to me about a best practice that they use where they've actually, they work collaboratively with their primary referral source, and if a patient does go into the hospital or a resident goes into the hospital and becomes a patient, they actually, you know, get on the phone and talk about, you know, what could the hospital have done differently, what could the nursing home have done differently. And so really building that collaboration, you know, gone are the days of us working in silos. Sharing with your payer sources, you know, interventions and projects that you're doing with rehospitalization. And then really involving family and caregivers in education around what can you do in your building and why is the hospital maybe not that best treatment option. I'm just trying to take a quick look at the questions.
Are you starting a new one?
Yeah, before we go on to the next measure.
Yeah, this is Rachel. I'm going to read one question that we have an answer to while Dawn's looking at some of the others, and if we don't get to all of them on this little break, we'll continue with them later. There's a question about when we say that CMS will include the item in 5-star in July or later, do we mean that CMS will list these measures on Nursing Home Compare site, or do you mean that it will be listed and it will also count toward the 5-star calculation? Is the answer different depending on the item? If so, identify, please. Thank you. And that's a great question. So right now, the 6 new measures are all posted on the Nursing Home Compare site. So if I'm looking for a nursing home for my mom and I go on Nursing Home Compare, I will see all 6 new measures. So I can see it for that center with a quick comparison to the state average and the national average. So what Dawn was saying about the 5-star quality measure, currently it only has 11 11 quality measures that comprise what you get. There are cut points and there's a calculation that determine whether you're a 1, 2, 3, 4, or 5 star on your quality measure rating. In July, when that 5-star quality measure is updated, CMS has indicated that it will be changed, but they have not told us yet how it will be calculated. So it will be changed to include 5 of the measures, the new measures. So it'll go from 11, you'll add the 5, and now there will be 16 that are in there. The last one is the long stay, hypnotic
and
anxiety. They are slating that to be added to the 5-star calculation in January of 17. Again, as of the open door forum call and checking the website this morning, they have not posted any instructions yet, any manual updates on how they will calculate those. And at the end, Dawn's going to have a slide to sort of show what happened last time they rebased that 5-star quality measure, and just sort of, we all have to understand, we don't know yet, but there could be some resetting of that measure in terms of how many nursing centers can be a 5, a 4, a 3, a 2. And we'll have to keep everyone posted, as we get information on that.
Yeah, and I'm going to answer one of the other questions that came in just for the sake of time, and then we'll move through, and maybe we'll kind of hold some of the questions towards the end. And if we don't get to all of the questions at the end, what we'll do is we'll make an FAQ, and we can get that out to everyone. There are a lot of good questions coming in. One question that I can answer pretty quickly is, if someone is readmitted within 30 days for a new diagnosis, does that go against your rates? And the answer to that is yes, it's all-cause readmission. Okay, so we're going to move to the next one, which is, there we go, short-stay emergency department visits. So this measure name is the percentage of short-stay residents with an outpatient emergency department visit after a nursing home admission. Again, the purpose of this one is very similar to the hospital one, in that it's thought that if the nursing home frequently sends residents to the emergency department, it may be an indication that the resident is not being properly assessed or cared for in the nursing home. And the thought is that if the resident can receive preventative care and access to physicians and nurse practitioners, it can prevent that emergency department visit. I think for me, this one goes back a little bit to what we were talking about a few minutes ago about that early intervention. And two, being able to share with families and caregivers the services that you're able to provide in your buildings, rather than needing to send them to the emergency department or for a hospital readmission. Again, this is a claims-based measure. It's on Nursing Home Compare, and we expect to see this one in July of 2016. And this would also be in the calculation for the 5-star rating. This measure description is that it determines the percentage of all new admissions or readmissions to a nursing home from a hospital where the resident had an outpatient emergency department visit within 30 days of entry or re-entry. The higher values of the short stay outpatient emergency department visit indicates a worse performance. So again, lower is better. The numerator and denominator window here is the same as rehospitalization. And again, for the numerator, the resident needs to meet the criteria. The resident would have been admitted to an emergency department within 30 days of entry or re-entry to the nursing home, regardless of whether they were discharged from the nursing home prior to the ED visit. And these emergency department visits are identified using Medicare Part B claims. And the resident was not admitted to the hospital or an inpatient stay or observation stay immediately after the visit to the emergency department. Inpatient and observation stays are determined using the Medicare Part A and B claims data. You can see the denominator here. It includes residents who entered or re-entered the nursing home within 1 day of discharge from an inpatient hospitalization, and that they entered or re-entered the nursing home within the targeted 12-month period. Excluded from this would be residents who did not have the fee-for-service Part A and Part B Medicare enrollment for the entire risk period, or that the resident was enrolled in hospice during their nursing home stay. The resident was comatose. Data was missing from any of the claims or MDS items used to construct the numerator or the denominator, or the resident did not have an initial MDS to use in constructing the covariates for risk adjustment. Again, here's the risk adjustment. I've pulled through some of those MDS items that they're going to use, and I've kind of already talked about how you may be able to use those as part of your quality efforts in doing some rapid cycle review. The measure calculation is on slide 23. And again, you can see here based on slide 24 how Pennsylvania is doing, and we're doing I think very well here, and we'll continue to work on this as well. So strategies, continue to be ongoing education on the healthcare service delivery capabilities of the nursing home to physicians, emergency departments, and hospitals. I can tell you that you can't just do this once. Hospitals have turnover of staff, new medical directors, those sorts of things well. So, strategically looking at how do you provide that ongoing education, and then communication to physicians and nurse practitioners at the time of notification. I think one of the key things when I was a novice nurse, I'm not going to say young because that will make me sound old, but when I was a novice nurse, my mentor had me write, exactly what I needed to communicate to the physician, and did I include everything that physician would need to know to make an educated decision on treatment. And nurse practitioner would fall into that same category. So for a diabetic patient, and I'm not saying I'm going to capture everything here, but what was the last dose of their medication? When is their next dose? What was their meal percentage? Did they have a medication that may interact and cause an elevation or a lower blood sugar? I think many of you probably use SBAR, and are you using that effectively? These are all important strategies to look at, because when that physician is needing to make a decision on the spot, do they have confidence in the staff's ability to treat that resident in the home and in the information that they're receiving? And so that's very, very important to influence that physician's decision. We're going to move next into the discharge to community measure. And I mentioned that we started looking at this one as part of the PHCA Quality Initiative Plan about a year ago. We were using different data, but again, working towards the same goal. So the measure's name is the percentage of short-stay residents who were successfully discharged to the community. The purpose for this one is for many short-stay residents, as we all know, returning to the community is the most important outcome for them. And so if a nursing home discharges few residents back to the home, to the community successfully, it may indicate that the nursing home is not properly assessing its residents who are admitted to the nursing home from the hospital, or adequately preparing to transition them back to the community. And I think as you look at improving your rate on this one, that second part of preparing them for transition back to the community really becomes very essential here. So far, the measures that we've spoken about are more internal while you're involving families. It's all kind of happening within your building. But this is really getting them ready to kind of set them free, if you will, back into the community. And how do you prepare them? No longer is discharge teaching just hospital bedside teaching. What are we doing as providers of long-term care to get folks ready to go back into the community? Again, this is a claims-based measure. It's available on Nursing Home Compare, and this is another one that we expect to be integrated into 5 Star coming July 2016. This measure determines the percentage of all new admissions in a nursing home from a hospital where the resident was discharged to the community within 100 calendar days of entry, and for 30 subsequent days they did not die, were not admitted to the hospital for an unplanned inpatient stay, and were not readmitted to the nursing home. In this case, lower value indicates worse performance, so higher is better. You can see here the the numerator and denominator 6 months with the lag months of 9 months again. And for this, the numerator includes they must meet the criteria, had a discharge assessment indicating discharge to community, so your coding becomes important on this. You don't want to code inaccurately. Was not admitted to a nursing home within 30 days of the community discharge and determined from Medicare claims, and did not have an unplanned inpatient hospital stay within 30 days of the community discharge and determined from the principal diagnosis and procedure codes on Medicare claims, and did not die within 30 days of the community discharge as determined from the Medicare enrollment database. The denominator includes the measure where residents were entered the nursing home within 1 day of discharge from inpatient hospitalization. That continues to be consistent. The hospitalizations are identified using Part A claims and entered the nursing home within that 12-month target period. Exclusion factors includes that did not have the fee-for-service Part A and B Medicare enrollment for the entire risk period. The resident was never enrolled in hospice. Resident was comatose. Data was missing, and that the resident did not have an initial MDS assessment. You can see a lot of these inclusion and exclusion criteria are pretty much the same. Risk adjustment here includes claims data that preceded the start date of the stay and information from the first MDS within 14 days of beginning the stay. One of the things that I pulled through here is 2 examples of the MDS criteria. You can see the other category. So again, when you're looking at potential success in the community, what are their support factors, and then also a lot of functional status criteria are pulled through on this measure. And so again, as you're kind of putting action plans in place and looking at rapid cycle and how do you improve this measure, these may be some of the things that you want to look at. There's the functional status one. So you can see the list is very large on this one. The calculation, and then here's how we're doing as a state on this measure. And Rachel's going to make a few comments on this one.
I just want to comment while we're on this measure, and since Dawn has also covered the rehospitalization measure, that we're at the point where on these measures we're starting to see multiple variations of them available to you and also to your partners. These measures are posted publicly, and I think it's important to understand some of the differences. And one key takeaway I just want to point out. So let's use discharge to community as an example. If you're all members of PHCA and thus AHCA, you have access to the long-term care trend tracker tool, where AHCA has developed with some partners, some academic partners, an MDS, solely MDS-based all-payer measure for discharge to community. You've been able to track that. You'll still have the ability to run those reports in trend tracker. And the first thing I noted when I pulled the state data was that we don't look as good here in this measure. And I got a little hung up on that, but I want to encourage everyone not to get so hung up on those differences between the measures, but to focus on where you fall in one measure versus your peers versus the state versus the nation. Sort of look at those comparisons. So stay within one measure. Pick your measure that you want to use to communicate. You have to know where you are on these CMS measures in particular, because they're available to the public very easily and to your partners. And not focus too much on the differences. I mean, Dawn's going in very great detail into some of these numerator and the denominator exclusions and then the risk adjustment. They're a little different in each measure. They are. I mean, a claims-based measure that has only Part A and Part B, no Medicare Advantage, versus an MDS measure that has all payers in it. They're going to be different. And try to understand those differences a little bit, but try to focus within one measure. And I'm not even going to talk about the 30-day rehospitalization, because as we all know, there are even more out there. You track your own potentially. I'm sure you all do. And then there are other measures that will be posted that CMS is developing that are part of the value-based purchasing. That SNF-RM measure is a little different. It'll make you crazy. So we're here to help if you have questions as you're trying to differentiate the 2 to 3 to 4 measures, and hopefully help keep you going on the right path. So I just wanted to point that out as we're in these measures, because I think that's really important, and I think it's just, we're just going in that direction right now of more and more of these measures out there. And another thing with risk-adjusted measures, you know, be cognizant of your actual rate and your risk-adjusted rate. So, you know, this national average, no one really focuses on the national average, but that's pretty key to these rates, because, you know, where you fall before risk adjustment and after is put in context with the national average. So when there's a risk-adjusted measure that looks high, you have to go and sort of dig into the details a little. And while CMS for the public won't be posting all 3 of those rates, the actual, the expected, and the risk-adjusted, they'll just post the risk-adjusted, but you'll have access to those 3 and can use that in your communications. And I know I've looked at the trend tracker template HCA is working on, and they are including all of those. I know you can download them in the data, and I'm hoping you can see them in the keys reports, but I haven't seen those yet.
If anyone wants to send us one, we won't share it. We'll just use it for our internal purposes. Why is my thing not moving? There we go. All right. So just a few interventions or strategies you can utilize. You know, again, discharge to community, your community partnerships and relationships become critical here. Having worked in a home health background, you know, not all home health perform the same, just like hospitals and nursing homes, and there is, you know, home health compare, and there's all sorts of ways, you know, that you can utilize those community resources, and you know, it now matters for you what happens when those residents, you know, leave your building. Your assisted living and personal care partners, you know, many of our assisted living and personal cares are doing a great job in starting to look at quality measures, and they're, you know, they're wanting to partner with you, and so you know, kind of having those conversations with them about, you know, what services do they provide, I think is very important. Engaging families and caregivers, you know, that becomes really important in assessing what's that post nursing home going to look like. And you know, sometimes folks don't have resources, so what's available in the community. I've already mentioned the importance of discharge teaching, and you know, it's I don't want to say it's a whole new world for us, but certainly I think that, you know, with more people going back to the community of a lot of our nursing homes, that's certainly an area of focus. And then, you know, looking at post-discharge follow-up, and you know, I've heard some kind of innovative ways that nursing homes are starting to get ahead of this with nurse navigators in the community, almost, you know, strategies that hospitals have used, but nursing homes are now either partnering or working collaboratively, and some are doing this on their own, using telehealth in the community. And so, you know, there's some, I'll say, higher tech, higher cost ways, and then there's just some, you know, basic ways of, you know, doing discharge phone calls. And so, you know, what does that look like for your building? This is a quick summary of all of the claims-based data, and it's really just a quick cheat sheet. All of this information we've covered, but we wanted to try to give you just a, you know, I said kind of if you need to pull something out and use it as part of your quality meetings, this may be something that you can use. We have about 15 minutes left, so I'm going to try to go through the rest of these fairly quickly so that we can get into kind of some of the things you can be doing to prepare for 5-star. So shifting gears here, we have the last short stay measure, which is improvement in function. And, you know, I think we're all aware that frequently the short stay residents have limitations in their function. They may be coming to you for rehab. This one is an MDS-based measure. And again, you know, the purpose of this measure is to determine if the resident is discharged from the nursing home, the percentage of the residents who gain more independence in transfer, locomotion, and walking during their episode. To me, this one is an important indicator on how they may successfully discharge to community. So you can see some of these measures start to relate to each other. And, you know, kind of you may want to map that out for yourselves on how does that begin to look. This measure assesses the percentage of short-stay residents. I've already kind of included this or gone over this. Let's just briefly look at the exclusion criteria. Residents who are in a coma, residents who have no impairment in these areas, residents with missing data again, and residents with an unplanned discharge, because in this case CMS is saying, well, the nursing home may have not had the opportunity to really provide therapeutic intervention that would have benefited the resident. Just a quick note that this short stay measure includes all residents who have resided in the facility for an episode of 100 days or fewer at the end of the target period. Again, Rachel was so kind to pull this information for us, and you can see where Pennsylvania ranks. And again, you know, this is an area where we have some work to do. We're below the national average. We're close, but we're not quite there. And so, you know, again, you know, kind of we have work to do in this area. Moving ahead here, I'm going to skip to slide 41. And just briefly look at the numerator. This is the number of nursing home episodes where the resident had negative mid-loss activities of daily living, change in score, and you can see that the mid-loss ADL score is defined as the sum of transfer, locomotion, and walk in the corridor self-performance. And so again, you know, a lot of this goes back to documentation and coding. And the numerator is the measure of this measure includes all short-stay residents who have had a valid discharge with return not anticipated assessment and a valid preceding 5-day assessment who were not identified as comatose, as having a prognosis of less than 6 months in hospice care, or as having a mid-loss ADL score greater than or equal to 1 based on the 5-day admission or admission assessment, and who did not have an unplanned discharge during the care episode. Some risk adjustment things just briefly to highlight here. You know, CMS has identified that characteristics and clinical conditions can influence the resident's ability to do this, so they've made adjustments for this. And some of the things that they include in that would be resident status on the prior assessment for age, cognitive impairment, heart failure, stroke, hip or other fracture, and the long-form activities of daily living scale scores. And you know, again, risk adjustment just permit for a more even comparison. Now on to the long stay measures, and just briefly to ground everybody on the definition of a long stay measure. It includes all residents who have resided in the nursing home for an episode of at least 101 days of the end of the target period. And the episode is a period of time spanning 1 or more stays, beginning with an admission and ending with either a discharge or the end of a target period, whichever comes first. The first one we're going to look at is the otherwise known as the locomotion measure, and this is the percentage of long-stay residents whose ability to move independently worsens. And you know, they've shortened this one to kind of just say long-stay locomotion measure. It evaluates the purpose of this measure is that it evaluates the quality of nursing home care with regard to loss of independence and locomotion for those long-stay residents. The reason for this is that loss of independence and locomotion can lead to undesirable outcomes. It increases the risk for hospitalization, pressure ulcers, musculoskeletal disorders, pneumonia, circulatory problems, and others, I'll just say. This is an MDS quality-based measure, and again, this is on Nursing Home Compare. We expect to see this in July, and the lower percentage indicates better performance on this one. The measure description, this one assesses the percentage of the long-stay residents who experienced a decline in independence and locomotion. It includes all long-stay residents except those for whom the measure cannot be calculated, and those for whom a decline in independence and locomotion does not necessarily indicate poor quality of care. The numerator and the denominator here, you can kind of see. I'm going to kind of quickly go through this. You can see, again, Pennsylvania has some work to do on this measure. And, certainly for me in preparing for this webinar and with Rachel pulling this data, the end of last month, it certainly gives us some opportunity to look at how can we support you through educational opportunities as well for the future. Moving to the last long-stay quality measure is the long-stay anti-anxiety or hypnotic medication. And this one is the percentage of long-stay residents who received an anti-anxiety or hypnotic medication. Purpose of this measure is, just like antipsychotics, these medications have been linked to adverse outcomes such as cognitive impairment, delirium, falls, and fractures. This is an MDS measure, and nursing home compare it is available. However, this is the one that we expect to be phased in later, probably January. This measure description, the long-stay anti-anxiety or hypnotic medication, this measure is used to assess the percentage of long-stay residents in nursing homes who receive those two types of medications. It excludes those residents who are receiving hospice care or have a life expectancy of less than 6 months, which I think is an important exclusionary criteria. The lower rates indicate better performance here, and I think many of the nursing homes have already integrated these two medications into processes where they're looking at their antipsychotics. So for many of you, you may already have processes in place for these medications. If not, that may be an area where you start. You can see the numerator here. It's a pretty simple one compared to some of the others. The exclusion criteria we already pretty much talked about, with the exception of if there's missing data, those sorts of things. Pennsylvania ranks under the national average, not by a lot, but we are under. And again, I think, as we start to focus on this medication, we'll see similar success and progress as we did with antipsychotics. This is just another summary slide of all of the MDS assessment quality measures. This one actually spills over into 2 slides, but it's a nice little cheat sheet at a quick glance. Some of the measures do not have risk adjustments on them, so that's why they're blank. So let's quickly shift gears. We have just a few minutes left to talk about preparing for July, and we'll continue to push information out to all of you as more information becomes available. Rachel mentioned that last year CMS rebased and kind of moved the goal line on us, and more changes are coming in July with these new measures. So you can see where we're at now, and she did a nice kind of table here from 2012 to 2016, and basically kind of looking at where are you now, and start looking at these measures and kind of planning for that change. Rachel, I don't know, do you want to go into anything else on this slide, or just kind of?
Yeah, I would just highlight the middle bars is the middle time period. So the bright orange in the middle of each star grouping is July 2014, and that is where in 2014 is really where we hit the peak of the number of 4- and 5-star buildings in Pennsylvania. We had, say, 37% at 4-star and almost 45% at 5-star. You add those up and you're over 80% you have with a 4- or 5-star building in Pennsylvania. And that's sort of, where CMS then ratcheted everything back. And the thing I would want to point out is that while they're adding new measures, they may also be revising those cut points to rebase these a little bit. I don't know that they will. It's just something to be cognizant of, and we will, obviously, HCA is advocating, and we are as well, very aggressively, that is not fair, and we would hope that would not happen. So you'll have an impact of the new measures being incorporated, and then you may have an impact of if CMS decides to move those lines again, and hopefully they will not. But right now, 4- and 5-star buildings are at about 53%. So 53% of the nursing facilities in Pennsylvania are at currently a 4- or 5-star rating on the quality 5-star component.
Thanks, Rachel. So just kind of wrapping up here, as soon as my slide advances. There we go. Some things that you can start to look at. One, Rachel and I looked first thing this morning to see if the new technical user's guide was available for the 5-star, and it's not out there yet. So we'll continue to check for that and make that available to our members, probably on the website. But some things to do in the interim. First of all, integrate into your quality assurance and performance improvement processes these new measures, and I encourage you to utilize a multidisciplinary approach. I mentioned with several measures today the impact that therapy or housekeeping activities, this really is a multidisciplinary approach, and I think the saying is it takes a village. It takes all of the disciplines really to ensure positive outcomes for our residents. Begin to review your data. If you haven't yet looked at your data, if you haven't pulled your reports, I would encourage you to do that. Explore some of the MDS elements, and I don't mean big, long quality improvement, programs on this, although maybe that is what is, you'll find out, but maybe some rapid quality cycles on just, spot checking some of those MDSs, ensuring accuracy of the coding. Review your processes, policies, and procedures as it relates to these quality measures, and start to look at how do some of these measures interrelate. I mentioned kind of some of the mobility, the locomotion ones. All of that starts to have an impact on what's the long-term outlook for the resident, whether they're going back to the community or staying within your building. A long-term care trend tracker continues to be a resource that is available to our members. We know that they're working on the quality measure piece, but if you're looking at your 5-star, there's some other reports out there that you can use. Know your story. I think this is really important as all of these measures start to have, different, I call them methodologies or different looks. Kind of know your story and know, if you have a high mental health population in your building, be able to share, these are our interventions, this is what we do, but this is why we will continue to, trend higher, and be able to have those conversations with your payers and your referral sources. And then start to educate your referral sources and payers on the 5-star changes. When CMS rebased last year, there were some tools that we put out on, how do you have the conversation with insurance companies? How do you have the conversation with families? We're going to start taking a look at those in preparation for the July changes, but the current drafts of those are out on our website, and so, I would encourage you to start thinking about, how do we position ourselves? How do we prepare ourselves for when the changes happen in July? Lastly, I just want to give you a few resources and educational opportunities. A lot of the materials that we prepared for today are from that first source there, the Nursing Home Compare Quality Measure Technical Specifications. We tried to summarize that, but if you're somebody who needs to read even more of the details, or you're interested in more of those MDS criteria, we can certainly share that with you, make it available on the website. We'd also invite you to attend the Pennsylvania Healthcare Association Quality Symposium this year. It is free for our members to attend, one or both days. The June 14th date is the Nursing Facility Focus Day. The June 15th date is our ALPC Focus Day. And, we're going to be going into some of these quality measures in much more deeper detail. And, finally, I would just say that, it's important to put a quality process in place, because as you can see, CMS is going to continue to execute on their quality plan and their plan to improve quality care, improve access, and all of the things that they've been working towards. So that process becomes very important, so that as these new measures come out, you're going to have to continue to move your focus along, and so having a process makes that a little bit easier, plus makes you feel a little bit more secure as you start to move your attention away, from one thing, that those changes are going to stay in place. Rachel, anything you want to add? I think with that, Abby, we'll turn it back over to you. And I know there's other questions that have come in, so we will, like I said, pull those down and do an FAQ and get that out to all of you.
Thanks, Dawn. Thanks for that presentation, and thanks to all who participated in today's webinar. Your certificates will be emailed before the end of today, and a recording of today's presentation will be available on PHCA's website. A reminder to please reply to the email with the certificate if you need the nursing credit certificates, and I'll email those to those who need them. If you'd like to learn more about the quality initiatives and measures, we again invite you to the PHCA Quality Symposium happening June 14th and 15th. Details are on the website, and I'll also include a link in the email that goes out with your certificate. Thank you for attending. This concludes today's webinar.